Michal, you have a lot about therapy, where the spectrum has expanded. Should we do hot, cold, whatever, transmural? So please.
Sure. Thank you both Stefans for the invite. It's a great pleasure being here. And thank you for giving me this topic, a really hot topic on endoscopic resection, a deep dive. There was obviously lots of development in the diagnostics over past decades. Right now, I think that the field of endoscopic resection is really evolving really fast. So this is the outline of my talk. So I will talk a little bit about the concept of diving deeper, not only in terms of diving deeper into evidence for colonic resection and rectal resection, but also why we are diving deeper into the colorectal wall. Because when we think about the concept of diving deeper, for many years we were doing endoscopic mucosal resection, which was perfectly sufficient for most cases of benign adenomas, which are obviously limited to the mucosal layer, and also for maybe for some superficial submucosal invasive lesions. On the other hand, over time, we developed further techniques like endoscopic submucosal dissection, which helps us to dive deeper into the colorectal wall, up to SM2, SM3 layer, so we can dissect a little bit more. And further on, we can also think about endoscopic full thickness resection, so we can go either through the entire wall or in some deeper layers, like in between the muscles, or entirely full thickness resection. And this was all allowed because there is a progress in a technique of resection and technique of closure. So this is one aspect. But the other important aspect is that for many years we were afraid of doing, or we considered it unnecessary because we were afraid of the risk of lymph node metastasis. So we were saying, oh, why should we dive deeper into the colorectal wall if there is increased risk of lymph node metastasis? Maybe it's not necessary, maybe surgery is the only way to go. But this is right now being challenged. And the first question, obviously, that comes to our mind is, can we predict the risk of lymph node metastasis? There are several risk factors that we may take into account, like lymphovascular invasion, which alone is associated with more or less 25% risk of lymph node metastasis. We can look at poor differentiation, around 12% risk of lymph node metastasis when considered alone. Then depth of submucosal invasion. There is a variety of, let's say, data. It's probably not perfect, but it is associated with somehow increased risk of lymph node metastasis. And then also a budding, which is a fourth factor for this reason. And obviously also positive vertical resection margin, but we are not quite sure, how much it associates with lymph node metastasis. And currently we have also some prediction tools, like the one developed in Japan, this nice study on nearly 5,000 T1 colorectal cancers from 27 high-volume institutions. So there was a development cohort and a validation cohort, and based on several different points, you can assess or predict the lymph node metastasis in T1 colorectal cancer, which seems to be quite critical because some of the patients may have comorbidities, so some patients may accept a higher risk of lymph node metastasis, or you may discuss with the patient. And this field is changing into more individualized or personalized risk assessment. But then the other thing that was really challenged was a depth of submucosal invasion, and this was one of very important studies, a meta-analysis of 67 studies with 21,000 patients. And as you can see, overall lymph node metastasis rate of around 11%, but in most cases, deep submucosal invasion was also together with some other risk factors like LVI, budding, and some other risk factors. But when you look at deep submucosal invasion as a solitary risk factor for lymph node metastasis, then the absolute risk in this meta-analysis was only around 2.5%, which makes it probably quite acceptable when we consider the oncological outcome for our patients. And what is probably even more important is that lymph node metastasis rate is a surrogate endpoint, because patients are not dying from lymph node metastasis themselves, they are dying from distant metastasis. And lymph node is just a prediction. And in surgery, if you have a positive lymph node, you usually give an adjuvant therapy. So let's have a closer look on the result of distant metastasis. And this is for local resection of rectal cancer, meta-analysis, 73 studies, nearly 5,000 patients. And if you have a look at the PT1 colorectal cancer, even high-risk colorectal cancer, the risk of distant recurrence in patients who did not receive any additional treatment was around 7%. And it was not significantly different as compared to completion TME, so surgical patients, or adjuvant chemoradiation therapy, which means that probably in some of the patients, the disease already spread, and further interventions may have quite limited impact. And in fact, there is a very recent study which I would like to highlight here, which also challenges the concept of a benefit of surgery after endoscopic removal of high-risk PT1 CRC. So this was a study published in Annals of Surgery at the end of the last year, and they compared a group which received local excision alone, around 400 patients, and local excision plus surgery. So what you can see on the left panel is the cumulative risk for recurrence, and it was almost significantly different in favor of local excision plus surgery, but the difference was relatively small. So as you can see, it's 2.5% as compared to 5.5%. But on the other hand, if you look at the right hand, on your right hand, and on the graph on the right hand, the cancer-specific survival was almost the same. It was 99.7% in local excision plus surgery, and it was 98% for local excision alone. So the difference is really, really small if we perform additional surgery. So I think that it really nicely challenges the concept that we may need surgery even after high-risk PT1 CRC removal. So what do we know more about colonic and rectal resection? And I will start with colonic resection, not talking only about cancers, but also precancerous lesions. So this is probably one of the hottest papers from the last year, comparing ESD versus piecemeal EMR in the colon. It was a multi-center randomized trial from France with large colonic lesions. So the primary aim or primary objective was to compare the recurrence at the first follow-up, and they found statistically significant difference in favor of ESD. So 0.6% recurrence rate in ESD group, 5.1% in piecemeal EMR. So there is a statistical difference, but I mean, the question is, how much do we gain out of it? So the difference in absolute terms is relatively small as well. And it comes at the price, because the price of doing colonic ESD in this situation is 35% complication as compared to 24% complication in piecemeal EMR group, which means that you can probably avoid some recurrences at the price of creating a little bit more complications. So the discussion on, what should we do is ongoing, and there was an immediate response from Michael Berg's group, a proponent of piecemeal EMR, with an analysis on what is the benefit of ESD in the right colon, just looking retrospectively on the prospective cohort of nearly 3,000 patients with right colon polyps larger than 20 millimeters in size. So they looked at their overall cancer rate, which was only around 4.4%, so not very, very high. And they specifically have had a look on low-risk colorectal cancer, so without LVI, without budding, that are probably potentially suitable for en bloc R0 resection, and actually they found a rate of low-risk cancer of 0.8% only, which translates into a number of ESDs to cure one colorectal cancer or one colonic cancer, 1 in 142. It means that you have to do 142 ESDs in the right colon to prevent, let's say, surgery and cure one additional patient. But then the other thing is that obviously there is some evidence that we can treat recurrence. So this is also report from David Tate and the group collaborating with Australian centers. Nearly 1,500 lesions with almost 15% recurrence rate. And what they found is actually that you may be quite successful in just simple endoscopic treatment of recurrent adenoma, 96% macroscopic successful resection of recurrent adenoma. And it came at only after one retreatment session, and no adverse events were directly linked to the therapy, and only 4% of patients required surgery, which further questions a little bit the necessity of performing colonic ESD or ESD in the right colon. But it may differ in the colon and in the rectum, and we knew a little bit about it in the past, and this is our data which was presented at UEG, and this data analyzes 2,500 large colorectal polyps, of which nearly 3/4 were in the colon and 1/4 were in the rectum. So what we found in this large cohort, that the first thing, we confirmed that PT1 cancer risk and high-grade dysplasia is much more prevalent in rectum as compared to colon. But we found also something which is, we think, really important, is that there is an increased risk of recurrence for rectal lesions, and the recurrence is associated with 9-fold increase of future colorectal cancer, because this was a first study which analyzed the entire cohort for a median follow-up of 9 years throughout the registries. It means that if you get the recurrence, your patients are at increased risk of getting cancer in the future, and probably especially for rectum, when recurrence happens more often, when lesions are more difficult to treat, and there is a higher risk of PT1 colorectal cancer, en bloc resection is really a way to go. So in the colon, still some doubts. In the rectum, we think that there is very, very little doubt whether we need ESD or EMR. And obviously, there is one more tool which is being used for adenomas and colorectal cancers. There is a meta-analysis on endoscopic full-thickness resection for colorectal lesions. Really nice pool, technical success, 87%, and R0 resection rate of around 80%. But there is still some recurrence rate, 12%, and 12% procedure-associated adverse events. So we have to guide our decision on whether to use this tool really wisely, so apply it to potential colorectal cancers that may be cured with full thickness resection, and also to difficult recurrent adenomas. And the technical success, you can see, are relatively high at around 85%, with margin negative resection of 77% in the other study. And finally, the final thing that I would like to tell about the colon is, does endoscopic treatment worsen outcomes in surgically treated patients with T1 cancer? This study was published last year in American Journal of Gastroenterology, showing us that there is no difference in primary resection as compared to resection after endoscopic resection, which failed to be curative. So we are not causing any harm to patients if we first treat a PT1 colorectal cancer endoscopically, and even if the patient needs further surgery, there is no harm as compared to primary surgery. So this is an important study on a very large cohort from Japan. So the last thing that I want to talk about is the latest evidence in rectal resection. At first, let's start with something relatively simple, but I think it's also quite important to know. There are some long-term results on long-term outcomes of endoscopic resections for rectal neuroendocrine tumors, a really large cohort, more than 400 patients, neuroendocrine tumors up to 2 centimeters in size. And what they found is this: it's really safe to remove those neuroendocrine tumors endoscopically, providing that there is no resection margin invasion and no angiolymphatic invasion. So they also developed a scoring system, and you can see those patients who have large size positive resection margin and lymphatic invasion, they are really at risk of lymph node metastasis. So probably those patients may benefit from further surgery. All the others are probably fine with endoscopic resection alone. And there are some new also developments. You've heard, those of you who were here yesterday at the satellite symposium, you've probably heard about the new kid on the block for the treatment of early rectal cancer, so-called EID, so endoscopic intramuscular dissection. And this is a very recent study published just 3 days ago in Gut. And this is the first large report on nearly 190 EIDs. Only 11 were discontinued, and there are some important features. The first feature is that they achieved R0 resection of nearly 100% or 100% for obviously benign lesions, also superficial submucosal invasive cancers, but also above 90% for deep submucosal invasive cancers, which tells us that we can dive deeper into the wall, because the risk is probably of lymph node metastasis is manageable, and R0 resection are really quite fine. And there are also some oncological outcomes which were reported here, relatively short as from oncological perspective, but this is a 3-year follow-up. And as you can see, if they also analyzed the deep submucosal invasive cancers only, if there were no additional risk factors apart from deep submucosal invasion, the patients, all of them went to active surveillance. None of them received any additional treatment. And there was 7% local regional recurrence, but no distant metastasis and no non-salvageable recurrence. And very similar results, honestly speaking, also for patients with deep submucosal invasion and one risk factor. Many of them, so almost 3/4, received only active surveillance and no distant metastasis, no non-salvageable recurrence. So it's really a promising thing. And one of the last things that I would like to talk about is endoscopy as an adjuvant treatment after chemoradiation therapy. This is also a very novel thing. A small analysis of 41 patients from 12 centers around Europe with a median follow-up of 16 months. This shows just the feasibility of the concept. So these were cancers, locally advanced cancers, which received neoadjuvant treatment, so chemoradiation, and they had a remaining adenoma/early cancer. And right now we demonstrate in this cohort that we can achieve very nice en bloc and R0 resection rates for those cancers, and most of those lesions turn out to be benign on histology. Those patients were always receiving surgical treatment beforehand. So this is really a deep dive right now. And this field will be really evolving because we know that from the TESAR trial and the TOTEM trial, which I will show you in a moment, that we can apply or we can add adjuvant treatment on top of endoscopic treatment in order to achieve really curative resection. So I would like to update you on the TESAR trial. This is a Dutch trial which is not yet published, but it's being presented during the congresses. Randomized trials between completion TME and or adjuvant chemoradiation therapy for after high-risk resection for rectal cancer. What you can see is that in the completion surgery, 3-year local recurrence in intention to treat was 0, but it was only 3% after adjuvant chemoradiotherapy, and those patients were all salvaged. Also in the surveillance group, the risk was not that high. So this shows that there will be a paradigm shift soon happening. So we will be resecting cancers locally and probably adding the chemoradiation on top of that. And this is a very recent thing, not about endoscopy, about surgery, but we can do what surgery right now, local surgery can do. And this is just to show you where we are heading to. These were T2 and T3 cancers, N0 cancers, which received local excision and chemoradiation therapy. And in this randomized trial, there was no difference between upfront surgery and local excision plus radiation therapy, even for T2, T3 cancers. So we are probably in the field of endoscopy moving toward like local resections, even for advanced cancer. So to conclude, what we know about the progress in endoscopic resection, we are getting a deeper dive into the colorectal wall, because we know that the submucosal invasion alone as a risk factor is a weak risk factor. We know that lymph node metastasis is a surrogate oncological outcome. We need hard oncological outcomes like distant metastasis or survival, and with that respect, local excision looks really good. About the latest evidence in colonic resection, ESD results in less recurrence but more complications. We need to treat a lot of lesions in the right colon to cure one cancer. But rectum may require en bloc, and there is no compromise for surgery with that respect. And the latest evidence in rectal resection, we can for sure resect neuroendocrine tumors, providing that there will be no additional risk factors, which I discussed with you. And there is this new concept of diving deeper, either with EID or full thickness resection for rectal cancers, which is really a paradigm shift for those patients. Thank you so much.
Thank you very much. We got 5 minutes, then Stefan will switch off the micro. Michal, you've been talking about cancer. One of the real problems is that it's not the frank cancer, which is recognized by everybody. The real problem is there are thousands of adenomas, and then there's the covered cancer. So it turns out that there is cancer. And I remember a very nice study from the Dutch screening program where everybody was, get an introduction and teaching and blah, 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 blah. And they had a few thousand colonoscopies and a few dozens cancers. And I think 40 of them were correctly recognized. So 60% were not recognized as cancer and EMR was started. What can we do here? It's rare and it's difficult to see.
It's a very good question, and I think that I have two also good answers. So first of all, I mean, if you look at the data that we presented in rectum, it probably doesn't matter so much because, I mean, if you look at the data, we should aim at en bloc resection. This means that probably, I mean, we need a little bit less of recognition of cancer. Obviously, there is an issue between T1 and T2 cancer. This is a new thing, but also looking at...
that means every large adenoma in the rectum has to undergo ESD?
Honestly speaking, I mean, I was not convinced before, but looking at some results which were presented before and also at our data, we believe that large adenomas in rectum should be removed en bloc. And it's also, I mean, in terms of complications and also simplicity, I mean, it's a way to go. I think that it's much more...
Is that feasible? So all rectal adenomas have to be sent to centers with expertise?
I think that it's feasible.
Big
I mean,
ones?
probably some of which are like 2 to 3 centimeters in size, they can be removed with like underwater EMR. We should probably aim at en bloc resection. This seems to be really crucial in the rectum.
So
not
rectum
in the colon.
ESD, okay, but the colon.
So then there was a response also from a Dutch group. There was a response for this really poor performance. And what they demonstrated is that you can train endoscopists really easily in recognizing cancer. And what they did, they improved it globally, countrywide. So there is another paper from the group, apart from the study in gut that you are referring to, with a poor recognition of cancer. There is another one which showed that with a very short training period, you can really upgrade your skills and you can reach much better results in terms of cancer recognition. And it's like a really population-based thing. So it's not at one expert center.
Real life. Okay. So we've got 2 minutes left. Some simple questions. Underwater, margin ablation, cold resection.
Yeah. So, I mean, this is...
Large polyps, yeah?
Yes, sure. So this is obviously not like the latest data, but we have some data on that. So there is really abundance of evidence that margin ablation works, though it comes from randomized trials, it comes from observational studies. But honestly speaking, the uptake of margin ablation, I wouldn't say that it's so widespread, at least in Europe. I'm not sure why.
But the message is it should be done.
It should be done. It should be done. You can boil down the recurrence rate from around 20% to, let's say, 5%. Okay. The Australian group, they are saying that they reach 1 or 2%. Probably it's very difficult.
It has to be done. Underwater, Ale Refugee says CO2 is a historical mistake, so everything should be underwater.
I mean, there is this underwater move, both in diagnostics and in therapy, also for ESD and also for EMR. There are certain benefits of it, and also some disadvantages. You have to have like optimal bowel preparation for this purpose. And some people are just a little bit afraid, but I think that it's slightly or slowly gaining attention. So you would say,
yes, kids do it at home.
Let's do it at home. Let's try it at home.
And cold for large adenoma, is it dead? Too high a recurrence rate, or are there certain subgroups?
Yeah, I think that it's essentially that. I mean, the trials that were done mostly like in Germany, they show really high recurrence rate after cold snare resection. So I think that as a general approach, it's that. Probably you can consider this in very high-risk patients, because obviously there is certain benefit in terms of the bleeding risk. So potentially for some granular lesions which are easy to remove at a patient at very high risk, yeah, probably you may consider. So it's always like individualized.
Patients. Now current is switched off, right? So thanks, guys, very much. It was a very good session.